This conference will now be recorded.
Hello everyone, I am Dr. Jhuma Bishwas. I am one of the mentor of MRCUG Health. Today I am going to discuss one of the important topic. It's very important for your antenatal care module in part 2 and also for part 1 as well, because nowadays in part 1 you will get questions related to guideline. So this topic is mainly twin pregnancy. It's not only from the NICE guideline. It's also from the GTG guideline, that is monochorionic twin pregnancy management. So I only discuss those important highlighted topic points that you need to remember during your exams. So let's start with that. So nowadays, you know that multiple pregnancy is a very common thing. Nowadays, the incidence is gradually increases because the number of artificial reproductive technique is also increases. So when we diagnose during our booking scan that is a multiple pregnancy, it's very important to determine the chorionicity and the amnioticity. And it's you can determine the chorionicity and the amnioticity after 14 weeks by seeing the number of placental mass and also the presence of the amniotic membrane and membrane thickness, and also by seeing the lambda and the T sign. If it is a dichorionic, then you will see two placental mass. If it is a monochorionic, usually we see a single placental mass, but sometimes we only see a bile of placenta as well in monochorionic pregnancy. If you see the membrane thickness is very thin, that is mostly it's a monochorionic. If it is thick, then it's a dichorionic. Lambda sign is mostly related to dichorionic, and the T sign is mostly related to monochorionic pregnancy. And also along with that, if you see a monochorionic pregnancy, we also need to do a trisomy screening by using the nuchal translucency and the maternal age. The problem with that, if it is a dichorionic pregnancy, you can individually assess the risk related to each baby, but if it is a monochorionic pregnancy, then you can only assess the risk related to that pregnancy. And as because the multiple pregnancy is a risk factor related to preeclampsia. So if you see along with the multiple pregnancy, if you see any additional PAT risk factor like the age or previous preeclampsia or any family history, in that situations you have to prescribe low dose aspirin from 12 weeks onward. As I mentioned, determination of the gestational age and the chorionicity should be between 11 to 13 weeks, where we can estimate the gestational age. Along with, we can also estimate the chorionicity, and we can also offer them for Down syndrome screening. So as we mentioned that the chorionicity can be detected by the number of placental mass, lambda sign or T sign, and membrane thickness. So here you can see it's a lambda sign. And this is, you can see intertwin membrane is very thin, and you can see there's a single placenta. So this is a pictures of the monochorionic pregnancy, monochorionic diamniotic pregnancy, and this is the pictures of the diamniotic dichorionic pregnancy. Regarding general care, obviously this is a very high risk pregnancy, so that care should be with a shared care. That means that include the specialist obstetrician, specialist midwife, and the sonographer. And usually in a singleton pregnancy, we do the full blood count in two settings, one at booking and one at 28 weeks of pregnancy. But always remember, in multiple pregnancy, we need to do it in a 3 times, that is at booking, then at 20 to 24 weeks of pregnancy, and then at 28 weeks of pregnancy. In dichorionic diamniotic pregnancy, total number of antenatal appointments should be 8. And among them, at least 2 of these appointments with the specialist obstetrician. So you can see that from 11 to 14 weeks from onward, then you have to start the appointment, and then from 20 weeks onward, that will be 4 weekly, like 20, 24, 28, 32, and 36 weeks. And without a scan, they need an additional appointment that between 16 to 34 weeks. So that means the total number of dichorionic diamniotic pregnancy appointment is 8. In case of monochorionic diamniotic twin pregnancy, the total number of appointment will be 11. So here you can see start from 11 to 14 weeks, that is the booking appointment. And from 16 weeks onward, every 2 weekly, they need an appointment to rule out any kind of twin transfusion syndrome up to 28 weeks. And then from 28 weeks onward, to rule out any kind of growth restriction. So every 2 weekly, they need an appointment. So so total number of appointment is 11. In case of triamniotic triplet pregnancy, total appointment should be 9. The same thing, that booking should be between 11 to 14 weeks, and from 20 weeks onward, every 4 weekly, they need an appointment. So total number is 9, and they need an additional appointment without a scan at 16 weeks. In case of dichorionic triamniotic or monochorionic triamniotic triplet, that means when they share the placenta, they need a more frequent appointment. That is, total number is 11. 11 to 14 weeks, that will be the booking appointment. And then from 16 weeks onward, they need every 2 weekly appointment. So total number of appointment is 11. So you can see, in case of dichorionic diamniotic, number of appointment is 8. Monochorionic diamniotic, 11. Triamniotic triplet pregnancy, that is 9. And dichorionic or monochorionic triamniotic triplet pregnancy, that will be 11. So regarding the follow-up, we already know that if it is a DCDA twin, every 4 weekly from 20 weeks onward, they need a scan. For MCDA twin, as because there is a high risk of twin-twin transfusion syndrome, in that situation, they need a 2 weekly scan. So from 16 weeks onward up to 24 weeks, every 2 weekly, they need a scan to rule out any kind of twin-twin transfusion syndrome. And then 4 weekly, they need a growth scan. Like in that situations, that should be because of growth, because after 24 weeks, the twin-twin transfusion syndrome risk is very less. So what is twin-twin transfusion syndrome? So twin-twin transfusion syndrome is that if the twin pregnancy share the placenta, there is a higher risk of that one baby can get more blood and one can get less. And this situation we call twin-twin transfusion syndrome. So regarding the twin-twin transfusion syndrome, there is a staging we call Quintero classification or Quintero staging, that is mainly based on the ultrasound and Doppler finding. So here you can see there's a total 5 number of stages. So the first one is the problem is in the amniotic fluid. So the donor will be oligohydramnios and recipient will be polyhydramnios. Stage 2 is the you see the along with the stage 1, there will be donor bladder is not visualized. Stage 3, that along with stage 2, if you see any abnormal Doppler findings, that will be stage 3. Stage 4 is that stage 3 plus hydrops, and stage 5 is any fetal demise. So how you remember this thing? So always remember A, B, C, H, D. A means that amniotic fluid abnormality, that is either poly or oligo. B is that bladder is not visualized, that's B. C, that is stage 2, is that critically abnormal Doppler. 4 is H, that is hydrops, and D is fetal demise. So A, B, C, H, D. So how are you going to manage a twin-twin transfusion syndrome? So in your questions, if they give you that the features of twin-twin transfusion syndrome, the first thing you have to do that you can't manage this patient by yourself. You have to refer the case to the fetomaternal specialist. So the first thing you can do, that is you have to refer the case to the fetomaternal specialist. That is the first and immediate actions you can do. And then based on the gestational age, then you can manage. If it is a less than 26 weeks, then you can treat it by fetoscopic laser ablation. That means you can ablate or destroy the connecting vessels over there rather than amnioreduction or septostomy. But if you see it's more than 26 weeks, in that situations, you can do either amnioreduction or septostomy. And after that, you can follow up the patients by weekly ultrasounds up to 2 weeks, and then after 2 weeks you can do 2 weekly ultrasound. And if you see that everything is fine, then in that situations you can decide the delivery between 34 to 36 plus 6 weeks of gestation. Okay, so always remember, if they give you the scenario, refer the case to the fetal-maternal specialist. That is the first thing you need to do. Less than 26 weeks, treated by the fetoscopic laser ablation. More than 26 weeks, amnioreduction or septostomy. Weekly ultrasound up to 2 weeks, then 2 weekly ultrasound till delivery. And delivery between 34 to 36 plus 6 weeks of gestation. If you see any kind of IUGR baby, the same thing. Firstly, you have to refer the case to the fetal-maternal unit, and then you need to do the fetal surveillance every 2 weekly along with the Doppler that we do for every kind of IUGR baby. If umbilical artery Doppler abnormal, then measure the ductus venosus waveform. Abnormal ductus venosus, consider delivery. In case of type 1 IUGR, you have to deliver between 34 to 36 weeks. Type 2 and type 3, you have to deliver by 32 weeks of gestation. So what does it mean, type 1, type 2, type 3? So this is the umbilical artery Doppler. This is the peak is the systolic and this is the diastolic. If you see that the end diastolic volume is reduced, that is the type 1 IUGR. Type 2 is that you can see that this is systolic, but every systolic there is a gap, so there is an absence of end diastolic flow. That is type 2. Type 3 is that you can see there is an absence of the end diastolic flow, but in the reverse direction there is a diastolic flow. That is called reversed end diastolic flow. So reduced end diastolic flow is the type 1. Type 2 is the absent end diastolic flow, and type 3 is the reverse end diastolic flow. So if you see there's only type 1 IUGR, then you can plan the delivery between 34 to 36 weeks of gestation. In case of type 2 and type 3, you can deliver by 32 weeks of gestation. Regarding of single fetal demise, in that situation, risk of surviving twin for the death or neurological death are 15% and 26% respectively. So the same thing, you have to refer the case to the fetal-maternal unit. And then you can arrange a fetal brain MRI 4 weeks after co-twin damage. Okay, so if you see that there's one baby is dead, you have to tell the mother there's a high risk of death or the neurological abnormality of the baby is very high. So in that situations, you have to refer the case to the fetal-maternal unit and do the fetal brain MRI 4 weeks after co-twin demise. So this is the time of delivery when you can deliver the baby. So uncomplicated DCDA twin at 37 weeks, MCDA twin at 36 weeks, MCMA twin between 32 to 33 plus 6 weeks of pregnancy. And usually DCDA, MCDA twin that can be delivered by vaginally if the first twin is cephalic. But if the first twin is non-cephalic at the time of birth, then they need cesarean section. In established labor, they need a continuous CTG monitoring, and we need to offer them an active management of third stage of labor to reduce the chance of PPH. So always remember DCDA, MCDA twin, if the first baby is cephalic, they can go for vaginal delivery. But for the MCMA twin, you have to deliver the baby by cesarean section. So again, timing and the mode of delivery for MCDA twin, that's from the 36 weeks onward after giving the steroids. For MCMA twin, that by the cesarean section, so that between, as we mentioned, between 32 to 33 plus 6 weeks. And I also written here so that you can remember, like twin transfusion syndrome between 34 to 36 plus 6 weeks. In case of type 1 IUGR between 34 to 36 weeks, and type 2 and type 3 IUGR that will be between 32 weeks. So that is all about the twin pregnancy you need to remember, and you will get at least 3 or 4 questions from your antenatal module from twin pregnancy. So I think this is you can use this recording as a and is a revise for the twin pregnancy, and this is the only important thing you need to remember for twin pregnancy. If you have any questions or query, you can ask me on the message. I'm happy to answer every questions of you. And if you get updated of our videos, then press the like button and also subscribe our YouTube channel. Thank you.